Hi everyone, welcome to the next chapter in the bone marrow or hematology section, and that is white blood cells. I'm hoping that you have covered all the RBCs and the anemias, and then you're ready to take on to the next chapter, which is WBCs. Now in this chapter, we'll not only be covering how the WBCs are formed or myelopoiesis, but we'll also take care of certain diseases which are in the non-cancerous zone, that is non-neoplastic. And then that means in the next video onwards, we'll take care of all the blood cancers, that is leukemias. So let's get going with how the white blood cells are formed. Why just white blood cells? How are cells in the bone marrow formed in general? So the father and mother of all the cells that we have is a pluripotent stem cell, which you very famously know as the hematopoietic stem cell also, and you have always studied that it is CD34 positive. From this pluripotent stem cell, the next to arise is a multipotent stem cell, and the word multi tells me that this will give rise to multiple things. Now in the bone marrow, there are three things: red blood cell, white blood cell, platelet. So this will give rise to everything. So this multipotent stem cell then divides into two, that is known as a common lymphoid progenitor. The word tells me it's going to give rise to all the lymphocytes, and then common myeloid progenitor, which will give rise to everything else. So as I said, that the common lymphoid progenitor will give rise to lymphocytes, and we know three lymphocytes: T lymphocyte, B lymphocyte, natural killer lymphocytes. All of them have been formed. But what about everything else in the bone marrow? This will remind you of that group project that you did in MBBS, where all the work was done by this one student. Although you had decided you will divide the work equally, but then there is one student who's possibly doing the work for the entire group, and everyone else is just sitting and taking care of just one thing, maybe editing one slide in the PPT, which all of us have gone through. I hope you were this student and not this. But nonetheless, common lymphoid progenitor said, I will only make lymphocytes. What about all the other white blood cells, red blood cells, platelets? The entire responsibility falls on the shoulder of the common myeloid progenitor. So now it's got a lot to do. So let's get going. Common myeloid progenitor then decides, I will make two colonies. And these are known as colony forming units. You've read this in physiology also. The first colony forming unit formed is going to be ME. If you see ME, M stands for megakaryocyte, means it's going to go and make the platelets. The E over here stands for erythroid, which means it's going to go and make the red blood cells. So red blood cells taken care of, platelets taken care of. Now I'm left with white blood cells. In the white blood cells, lymphocytes are also taken care of. Only the rest of the white blood cells are left. And for that, another colony forming unit is formed, that is known as GM. G stands for granulocyte and M for monocyte. So of course the monocyte is going to form monocytes, which is so obvious. Granulocyte means all the others which have granules, which is the leftover WBCs. NBE, the body that organizes all your exams also. NBE, that is neutrophil, basophil and eosinophil. So now I know that all of the bone marrow cells are prepared. The RBCs have been prepared, the platelets have been prepared, and in the WBCs, we've got all the 5 WBCs also ready in front of us. Out of these, at every step, there are certain markers and CD markers that you have to know, which are going to be tough, but I want to finish the tough part first. Out of these, I've told you that the first one, that is the hematopoietic stem cell, is CD34 positive, but what about everything else that I've taught you? Starting with the lymphocytes, the T lymphocytes are going to be CD1 to 8 and 28 positive. I think that's the best way of learning it. 1 to 8, 28. The B cells are going to go in doubles. So that means you start from CD10. Thereafter, double of 10 is 20. So you go in the series of 20. That is 19, 20, 21, 22, 23. Okay, after 20, the double of that is 40. So in the series of 40, it is CD40 positive, and double of 40 is 80. So not exactly 80, but two things below 80, that is 79A and 79B. So I think that's the best way of learning it. 10, double 20, double 40 and very close to 80. Coming to natural killer cells. Natural killer cells, we call it as a very, very powerful wrestler. Natural killer. It can naturally kill all the virus particles. You've read this in immunology. So it is going to be CD16, CD56 and CD94 positive. How we've learnt it is that a very powerful person will always have a 16-inch bicep, and then of course the favorite joke that went around on social media, that is the 56-inch chest, and then of course such a person will be very heavy also, that is the weight will be 94 kg. So 16-inch bicep, 56-inch chest and 94 kg weight, that's the wrestler natural killer cell. So all your lymphocytes are done. Now let's go on to the myeloid series. The myeloid, of course, it will be positive for myeloperoxidase, along with that 1333, so CD13 and CD33 positive. Coming to the monocytes. Monocytes are CD11, CD14 and CD 1464 positive. And how am I supposed to learn this, ma'am? Again, very simple. Mono sounds like as if someone has been left single, forever single. So 1-1 means the person is single. 14th Feb also he's single, Valentine's Day, which is quite sad, and single till he dies, that is single till 64 years of age. So repeating, 1-1 single, 14th Feb single, single till he dies 64. Sorry for this depressing mnemonic, but that's for the single monocyte. Coming to the megakaryocyte. So megakaryocyte is going to be CD41, CD42 and CD61 positive. How I've learnt it? For all the PUBG fans, in case you have played PUBG once upon a time, there was a very famous and deadly gun called the M416 gun, and that is how I've learnt it. M is for the deadly big gun, that is big megakaryocyte, and 4161 is how I've learnt as the marker of 4161, that is megakaryocyte. Coming to the last one, do RBCs also have some kind of a CD marker? Yes, which is not commonly known, but that is known as CD71. I've written it red for red blood cells. What is CD71? It's nothing but the other name, because RBCs have definitely something to do with transferrin. That's the other name for transferrin receptor. How I've learnt it is that transferrin can easily transform into 7-1. So that's CD71. All your CD markers are done. We can get back to the story. I know how all of these are formed. Now let me start and go into a little more detail. It's not that one fine day of proper neutrophil came into the blood. No, there has been a series of events. So whenever a proper cell comes into the blood, there is a backdrop in the story that is happening. What you're seeing over here is in the peripheral blood, but what has happened in the bone marrow, that is very important to know. So in the bone marrow, the first cell of every lineage has been a blast. So common sense tells me that monoblast will give rise to monocyte, lymphoblast will give rise to lymphocyte, then a myeloblast will give rise to all the things that are left, that is NBE, neutrophil, basophil, eosinophil. Repeating, monoblast, monocyte, lymphoblast, lymphocyte, and myeloblast will give rise to everything else. So should we see photos of these? Let's get going. Before that, I'm starting with this, although see, it's simple. Lymphoblast, lymphocyte, done. Monoblast, monocyte, done. I have to see how myeloblast can give rise to 3 different cells. So this pathway is important for me to know. First, you learn these with the images that I have drawn, pictorial representation, and then I'll show you the actual photos. The first one over here is going to be a myeloblast. Myeloblast tells me that everything means the first cell is always labeled as a blast. How did I identify it? Because it has this rod, needle-like rod, which is known as an OR rod, which is very important and is asked a lot in the exam. After myeloblast, the next cell is the promyelocyte. See the pro in the series. Pro is always like the big B, and that is why this cell you will see is the biggest or the largest cell of this series. After that, if I remove the word pro, I'm left with myelocyte. How to identify myelocyte? Look at the shape of the nucleus. It is going to have a D-shaped nucleus. Please have a look at it again. Now in front of this myelo, I will add another word, that is metamyelocyte, or I can abbreviate it as MM. Metamyelocyte. So I realized its nucleus is also looking like an M only. Means there is a certain indentation that has happened in the nucleus. If that indentation goes deeper, it goes deeper, so much so that more than 50% of the nucleus is indented. Now it started looking like a hairband that girls wear. So that is known as a band form. And from this, finally, I can have the 3 mature cells. It could be a neutrophil, it could be a basophil, or it could be an eosinophil. So first get used to the names. First one was a blast with an OR rod. Then we had a pro, biggest one, that is promyelocyte. We cut the pro, we have a myelocyte. We add an M in front of it, we have metamyelocyte. Then we have a band form, and finally we have NBE. So let's have a look at it with the actual pictures. So the first one that we have is a myeloblast, and I can easily identify it because I can see a lot of OR rods which are forming over here. After that, the next cell that comes up is the largest in the series, which is going to be the promyelocyte. Next one comes out to be myelocyte, which I told you will have a D-shaped nucleus which is forming inside it, so that's done. The next one will be a metamyelocyte, which will have an indentation in the nucleus looking like an M. When the indentation will become very, very deep, that will start looking like a hairband thereafter. And finally, either the neutrophils, basophils, or eosinophils will form. So your next question is that at what stage of this entire cycle is it decided that how does this myeloblast know that will I make a neutrophil, will I make basophil, will I make eosinophil? How does this myeloblast know its destiny? It's asking you that, are you an astrologer? Can you tell me the destiny? What will I make in the future? So what is your future dependent on? What you feel? I mean, at your level, everyone believes that my future will be decided the day I decide which branch I want to pursue my MD in. Same way, the myeloblast also feels that whenever I'll get to know what am I pursuing my MD in, I will know my future. So it is at this stage that it is decided that, again, why did I say MD? Because myelocyte has a D-shaped nucleus. So at this stage, it is decided that whether it will form a neutrophil, a basophil, or an eosinophil. Something important for INICET. Finally, you're done. Before I move forward and I show you the different kind of blasts and their photos, just a small little test. What do you think this cell is which has been indented pretty deep, almost like a hairband? So this becomes a band form. Which is the cell which is only slightly indented? This must be a metamyelocyte. And what is this cell which is kind of having a D-shaped nucleus? That is going to be the MD, that is myelocyte. Now let me go forward. I had studied that from the myeloblast, all these three cells will form, and from the lymphoblast, a lymphocyte will form. They ask you pictures of these two. Myeloblast versus lymphoblast pictures are asked. So myeloblast picture everyone knows because it's very famous for having these OR rods. And there's another question of OR rods which has been asked in INICET, that actually which granules are fusing and which are the organelles which are helping in the formation of these OR rods. It is the lysosomal granules. If you're confirmed, very good. If you're doubtful that, ma'am, I'm not too good at picking up OR rods, are there any stains? Of course, for myeloblast, the stain has to be MPO, that is myeloperoxidase. Even Sudan black B is positive, and even CAE, that is chloroacetate esterase, is positive. Repeating, myeloperoxidase, all short form. Sudan black B is positive, chloroacetate esterase is positive, that is a myeloblast. It shows you OR rods. But the blast that will not show you OR rods is going to be a lymphoblast. You will see, I will zoom in, you can see one big cell over here which is a blast, but do you see any line inside it like an OR rod? No. So when you don't see an OR rod, that is a lymphoblast, but ma'am, that could be any other cell also. So if you have to confirm lymphoblast, there are two stains. The most important one is going to be the PAS stain, that is periodic acid Schiff, and we have always studied P for PAS and P for pink. I would want you to zoom into this slide, and because zooming in will give you more clarity on what I'm trying to show you. Of course, ma'am, this is showing me a lot of pinkishness that is there in the cell. So this is PAS positive. But if you look carefully, the entire cell, and you need a really, good vision to actually visualize this, that it's not that the entire cell is becoming pink. It is actually that pink color is coming in these dots and blocks. So I will now call it the dot blot or block positivity, any such term written. Either they call it block positivity or the dot blot positivity. As I will go forward, I will tell you lymphoblasts are of two types. There is a T lymphoblast, there is a B lymphoblast. So PAS will give me positivity for every lymphoblast. But if I have to confirm whether it is T category or B category, I will do acid phosphatase stain, because acid phosphatase will be positive in the T lymphoblast category. Now finally lymphoblasts are done. I'm left with what? The last one was monoblast, which was giving rise to monocytes. You don't need to know the picture of a monoblast, but they will ask you what is the stain, and that is NSE. Before I proceed, I hope you did not call this NSE as the neuron specific enolase, because this is a tumor marker that I have taught you in the neoplasia chapter, which is going to be positive for all the neuroendocrine tumors because it had the word neuron. Here, this is not the NSE that I'm talking about. The NSE in hemat is known as non-specific esterase. How I have learnt it is that when they write monoblast or anything to do with monoblast, monocyte, which esterase, you will say mononoblast, means non-specific esterase is going to be positive. Why did I give you this vague mnemonic out of the blue? Because these esterases you will mess up. When we had said myeloblast, the name of the esterase was chloroacetate esterase. Now when I'm saying monoblast, that's why I said mononoblast, because it is non-specific esterase positive. So if I have to go back to the blast story and just ask you what are the special stains, you will say for myeloblast it is myeloperoxidase, Sudan black B and chloroacetate esterase. For lymphoblast it is going to be PAS positivity in the form of those dot blocks and blocks, and also for T lymphoblast it is going to be acid phosphatase. For monoblast it is going to be mononoblast, that is non-specific esterase. All your blasts are done, but what about the story of the mature cells? So before going on to the mature cell story, can you tell me what blast is this? Myeloblast, monoblast or lymphoblast? I hope all of you could visualize these OR rods over here and you didn't mess up over here. I'm giving you small tests because these topics I have seen tend to mess up in the exam also. Students do that. So this is a myeloblast. Now you're done with all the blasts. We are going on to the story of mature cells, ma'am. If today I want to get a blood test done, forget the bone marrow, I want to get a blood test done from my venous blood, what are the cells that I'm going to find? So let me first know the normal count. How many total cells will you find? Total leukocyte count, written as TLC, total WBC count, is 4K to 11K. That is 4,000 to 11,000 per cubic mm. This is your normal total count, which means that by chance, if someone comes to you with more than 11,000 TLC, you will say that the counts are increased. That is a case of leukocytosis. Whereas if the counts are less than 4,000, you'll say, oh, the WBC count has gone down, and that is known as leukopenia. That's not enough. Only knowing the total count, you can't just know that in the GT what are the total marks that you got. Don't you have to do subject-wise analysis to know which is stronger and which is weaker? So just knowing the total WBC count is not enough. You also have to know what is DLC, that is differential leukocyte count, which will tell you which cell is present in what proportion. We always learn it as NLMEB. In every lab report also it is written as NLMEB: neutrophil, lymphocyte, monocyte, eosinophil, basophil. For the second year students, there's a very interesting mnemonic by which you can learn it, and that is never let monkeys eat bananas, which will always tell you that NLMEB is going to be from the maximum quantity to the minimum quantity that is present in the blood. I know all of you have always read these as percentages. And just giving you a vague idea, most of you have read that neutrophils are present 40 to 70%. Then you've read that 20 to 40% are going to be the lymphocytes. Then you've read somewhere up to 10%, or you can say 1 to 10% are going to be the monocytes, 1 to 5% are the eosinophils, and less than 1% are the basophils. Mostly students have learnt it in the form of these percentages. I believe knowing percentages is not enough. If I say 40%, I'm saying 40% of how much? 40% of the total count. Let's assume the total count is 10,000. So if I'm saying 40%, I'm trying to say that, oh, it is 4,000. So it's better that you learn the absolute counts. So that is what will give you more clarity in the exam also. So neutrophils are between 2,000 to 7,000. Lymphocytes are between 1,000 to 3,000. The lower limit 1,000. So monocytes have to be less than that. Monocytes are less than 1,000. Do it half. The eosinophils are less than 500 and basophils are less than 100. So very easy to learn. Neutrophils are what? 2K to 7K. Lymphocytes are 1K to 3K. Monocytes are less than 1K. Eosinophils less than 500 and basophil less than 100. In percentages, I said basophil is less than 1% because so many times in your blood you don't even see any basophil. 0 could be the basophil count, and that is also perfectly normal. Now it's not enough to know their names and numbers. It is also important to differentiate them. How does a neutrophil look like? So if you look carefully, the nucleus is the characteristic one over here. The nucleus has lobes. Normally the nucleus has 3 to 5 lobes, which are important for us to know. Now please note, when did I tell you that the neutrophil count will be increased in the blood, what you call as neutrophilia? All acute inflammations are going to show you increase in neutrophils. However, I hope you remember the acute inflammation which does not show you increase in neutrophils is going to be typhoid. But otherwise, every bacterial infection, every acute inflammation that comes up your way will show you neutrophilia. After neutrophils, the next cell that we have is lymphocytes. There is nothing special about a lymphocyte that I can tell you. It's going to be a normal looking cell, and inside it there will be a normal looking round nucleus. As I said, there is nothing special about it. So hence I call it as a single round nucleus. But when is it increased? So in acute inflammations, if neutrophils were increased, so in chronic inflammation, it is going to be lymphocytes that will be increased. Again, there will always be an exception. So if you remember that except a case of pseudomonas, chronic pseudomonas, only in this condition the lymphocytes were not increased. Other than that, all chronic inflammations show you lymphocyte increase. How can you forget in our country TB? Now TB, I agree, is a bacterial infection, but TB more commonly shows you elevation of lymphocytes. You can't forget this, especially living in India. And lastly, when you have any viral infection like COVID or any other viral infection, that also shows you increase in lymphocytes. So we are going in the same order of NL-MEB. We've seen a neutrophil with lobes. We have seen a simple looking lymphocyte. We go on to M, that is monocyte. A monocyte is something which is, again, whenever I write M, it has to be the nucleus also looking like that. I can see the nucleus is looking like a kidney. So I call it a kidney or a reniform nucleus. And M for M, that it is going to be increased in the infection malaria. This is so essential for me because when the malaria season comes following the rainy season, I know that I'm going to get hundreds of smears on a daily basis where the clinicians would be suspecting people with fever and chills, and the clinician would be suspecting malaria. But then when I can look at the report, I will know that malaria patients, not always, but in most cases, show you elevation of monocyte. Apart from that, you are too early in the course, but I have to complete this, that there are two cancers which can show you elevation of monocytes that go by the name of JMML and CMML. Okay, J over here stands for juvenile because this happens in children, and C stands for chronic because this happens in adults. Rest everything is the same. That is myelomonocytic leukemia. If I repeat this once again, taking each into account, so what is going to be JMML? It is juvenile myelomonocytic leukemia in children. What is CMML? Chronic myelomonocytic leukemia in adults. So the monocytic word is coming into it, hence I know monocytes will be elevated. NLM done, going on to the E, and that is going to be the eosinophils. One of the most different looking ones, because if you look at the cytoplasm, it is going to have very orangish pink granules. I would want you to zoom in also and see once that overall the appearance of these granules is going to be very orange pink, and the nucleus is very different. Some people say they look like headphones, some people say they look like spectacles. I mean, everyone has a different imagination, but spectacle shaped nucleus is what is seen. Eosinophils are elevated in two reasons, and you need to know both because this is something you'll see in your day-to-day practice. Number one, whenever there is allergy, like let's say there's a patient of asthma, it's an allergy, you will see increase in eosinophils. Season changes. So many times when autumn comes, spring comes, people suddenly show a lot of increase in eosinophils. That's an allergy. Someone has a drug allergy, someone has a food allergy, someone has just house dust allergy. Any allergy will show increase in eosinophils. Also parasitic infections, like someone has Giardia lamblia infection, Entamoeba histolytica infection, hookworm infection. Parasitic infections show you increase in eosinophils. But why is that so? TB does not show you increase in eosinophils, because the reason is that our body is adapted in such a way that whenever a parasite comes into the system, eosinophil has been given that responsibility that, hey, you have to take care of this parasite. So if a hookworm has come into our body, the reason that eosinophils are increasing is that they will go and kill the hookworm. They will go and charge and destroy the hookworm. How? Eosinophils are going to make a protein which is known as MBP, major basic protein. This question has been asked a lot in PYQs, one-liners, the ones that used to come 5 years ago. Major basic protein is produced by whom? It is produced by eosinophils, so that it can go and kill what? This major basic protein will go and kill the parasitic infections. Now coming to NLMEB, last one, that is basophil. Everything goes for BBB because basophil will show you blue-black granules. There are so many granules that, ma'am, I can't see the nucleus properly. The granules have been so thick and so black in color that there is a nucleus. Of course, every cell has to have it, but the granules have totally covered it. I will say the blue-black granules are obscuring the nucleus. It is increased in a leukemia, that is chronic myeloid leukemia, where it is diagnostic. I mean, it has to be increased in CML. It is also increased in polycythemia vera. I mean, you know, polycythemia vera is RBC increasing, hemoglobin increasing. Polycythemia means hemoglobin more, but that's the catch which I will teach you, that basophils can also be more. Now, as I told you, basophil count is the least, less than 1%. So seeing them in the blood can be quite challenging. So is there a special stain that we have for basophils? Not just for basophil, the same goes on for mast cells also. Mostly, you know, basophil and mast cells are said to be cousin brothers. Basophil is something that you're finding in the blood. Similar cousin brother of it is mast cell, which you find in the skin and the tissues. So everything about them looks similar. For both of them, there is a special stain called toluidine blue. If I give you a bottle of toluidine blue solution, what do you think will be the color of the solution? Ma'am, what a dumb question. Toluidine blue will look blue in color. I expected that when I will look at it under the microscope also, it will look blue in color, but under the microscope, it started giving me purple color granules in the basophil. There are purple color granules of basophil, and you're like, this is something different. This is two-faced. This is like the topper of your class who told you something else, that, oh, I haven't studied and I'm going to fail the exam. But on the day of the exam, he has started showing a different color and he has answered maximum questions, taken maximum answer sheets and just topped the exam. What do you call such people? Two-faced. What do you call such stains? They are metachromatic, metachroma, different colors. So a bottle solution of toluidine blue looks blue, but when you look at it under the microscope, the basophil is not looking blue, it is looking purple. It's changed the color, and that is metachromatic stain. So toluidine blue, special stain for basophil, very famous BYQ. Finally, you're done with all, and a quick test that I would want you to gather over here. The first cell that we see with nuclear lobes is going to be the neutrophil. The simple looking one that we have is going to be the lymphocyte. The one with the kidney shape over here is going to be the monocyte reniform. The one which is orangish and is going to have spectacle shaped nucleus is going to be the eosinophil, and the blue-black where I can't see the nucleus at all is going to be a basophil. What is this cell on the side? Because this is a precursor. Remember I told you a series of myeloblast, promyelocyte, myelocyte, metamyelocyte, band form. Yes, this looks like a band form also that has come into the blood. So these are just quick tests, and this is the same image which is given over and over in the exam, because on Google this is the only image which has all the 5 blood cells in one picture. You're done with all the normal. I want to take exactly 5 minutes and finish off some non-cancerous things that can come up in the exam. The first one is that what are the non-neoplastic, means no leukemia I'm talking about here. The first one is hypersegmented neutrophils. I told you normal neutrophils have 3 to 5 lobes, but if they have more than equal to 5 lobes, like over here, I can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, so many of them. So these are known as hypersegmented neutrophils, which I taught you in a case of megaloblastic anemia. But what if there are no segmentations? What if there are less than 3 lobes? Like I can see only 2 lobes over here. Then ma'am, you will call it hyposegmented. So I know that normal is 3 to 5. Anything less than 3 will become hyposegmented, and anything more than 5 will become hypersegmented. So hypersegmented was seen in megaloblastic, and hyposegmented is seen in something called as Pelger-Hewitt anomaly. So whenever you have a neutrophil with 2 nuclei, it is known as Pelger-Hewitt anomaly. It is usually because of some genetic condition. You don't have to know the genes. But what is pseudo-Pelger-Hewitt anomaly, ma'am? Pseudo-Pelger-Hewitt also will show you the same neutrophils. The only reason for calling it pseudo is that this has not happened because of a genetic condition. This has happened due to some other condition that the patient has. Like for example, patient is a case of CML, chronic myeloid leukemia. So it's primarily a blood cancer, and along with that, these neutrophils are seen. Patient is a case of MDS, myelodysplastic syndrome, and along with that, these hyposegmented neutrophils are seen. So when the primary reason is something else and these are seen as a tag along, it is pseudo-Pelger-Hewitt. When the primary reason is genetic causing Pelger-Hewitt anomaly, 2 lobes, that is just known as Pelger-Hewitt anomaly. Finally, hyper and hypo are done. Moving on to the next one, what is May-Heglin anomaly? So the way you write May-Heglin, I can take up M, Y and H, and that will tell me the gene mutation, that is MYH9 gene mutation. Learn the entire thing. What is seen in May-Heglin anomaly? So from May, I obviously gathered all of your MYH gene. From Glyn, I will gather whatever is seen. Number 1, it is going to show you giant platelets. So let me look at this picture. These cells, of course, without the nucleus are RBCs. This one happens to be the WBC. And over here, the other cell that is put up over here is a platelet. Normally, a platelet is just a tiny little dot. But over here, I can see a very big platelet, that is a giant platelet. So G is done. Next, I know that the platelet count also goes down. There is low platelet count. And the third one is there are inclusion bodies. If I zoom into this WBC, I will see that there is some vague bluish color appearance that is present, which means there are inclusions, and I have written them to be Dole body-like inclusions, which I will tell you what it means. First, May-Heglin anomaly is a condition in which there are giant platelets, there are low platelet counts, and there are inclusions similar to Dole bodies. So ma'am, what exactly are Dole bodies? I've got you the same image again. It's the same white blood cell, and in that I can see some blue color body here, some blue color body here. So what exactly is a Dole body? D and E, Dole. Take the first and the last alphabet. This is nothing but a dilated endoplasmic reticulum, and this is formed whenever the patient has severe bacterial infection or sepsis. So in May-Heglin anomaly, you see Dole body, and this Dole body has been asked a lot of times. Dole body is dilated endoplasmic reticulum seen in sepsis. Coming to the fourth condition, and that is the one in which there are large granules, large cytoplasmic granules. So first let me show you the picture. I can see a neutrophil in which there are button-like, very big granules that are present. That is a Shediac-Higashi syndrome. So Shediac-Higashi syndrome I have taught you way back in the second chapter, where I taught you it is a List gene defect. List gene tells me that this is a problem in phagolysosome formation. And quickly revising, because the mnemonic for Shediac-Higashi was Shediac-Higashi, so first and foremost, C stands for CNS or neurological symptoms that the child will have, like the mother will say there are delayed milestones, the child is not getting good marks in school. HE for hemorrhage, there will be a lot of bleeding manifestations that the child will have. DI for decreased immunity, so the child will come to you with lots and lots of infections because the immunity is low. A for the most characteristic albinism, the pigmentation is low, that is why the child's eyebrows and eyelashes and hair, they will all be silvery grey in color. And lastly, K for coarse cytoplasmic granules is exactly what you're seeing over here. You know, similar coarse cytoplasmic granules are also seen. You can see, but they're a little smaller, but lots of granules are also noted in the neutrophil in a situation known as Alder-Rille syndrome. Not very important for other exams except I&I. And Alder-Rille syndrome is seen with lysosomal storage diseases, especially the ones that fall under the category of mucopolysaccharidosis. So giving you a very quick recap, the first one was more than 5 lobes, that is hypersegmented neutrophil seen in Miguel anemia. Less than 3 lobes is hyposegmented, known as Pelger-Hewitt and pseudo-Pelger-Hewitt. May-Heglin anomaly, you remember Glynn and everything, giant platelets, low platelet count and inclusions. Then next we have something called large granules. Either you can see big granules in Shediac-Higashi, or you can see some small granules in Alder-Rille syndrome. Coming to a few MCQs, the first question is, what is the absolute count range for eosinophils? So if you remember, neutrophils were 2000 to 7000, then lymphocytes were 1000 to 3000, monocytes were less than 1000, and eosinophils were less than 500, which is the answer over here. The last question is, what is the genetic mutation in May-Heglin? MYH is how we selected it, and I clearly told you, remember MYH9, which is important. I hope you also remember that List gene is for Shediac-Higashi syndrome, and if you've not forgotten, Wiskott-Aldrich syndrome is what you studied in immunology chapter. You're done with the first introductory part, and now we can go on to the main chapter, that is cancers, taking care of all the leukemias.